program. Uh, so this is psychodynamic approaches in child and adolescent psychiatry. And perhaps this is an area which is not very much discussed in academic forums. And that itself makes one really curious to know how does one approach, how a therapist can actually thread a classical psychodynamic approach into therapy and assessment for children. So today's session is delivered by none other than Dr. Verghese P. Punnus. He's principal of Government Medical College, Kottayam, and professor of psychiatry. Sir has many other international titles to really cherish him, and what he's really known for is as professor of psychiatry of Government Medical College, Kottayam. And for me, this is a special moment because Sir was also my teacher during my internship days, and it's truly an honor, Sir, to host you this evening. As for me, I'm Dr. Rachna George. I'm a faculty at the Child and Adolescent Psychiatry Unit at the Christian Medical College, Vellore, and I'll be your host for today's session. So this is a special session which is hosted by the IPS Faculty Development Committee in association with the IPS Psychotherapy Specialty Section, the IPS PG and UG Education.
I think we lost Rachna somewhere. I think she will join in a minute, and I want to continue till she joins because many of the office bearers of Indian Psychiatry Society, the president, the secretary, the other people are part of the American Association of Psychiatry program, which is going on. So many of them may not have turned up. Rachna, we lost you. Over to you. Back.
Okay, sorry, sir. Yes. So I thank you all for your gracious presence and our psychiatry at the All India Institute of Medical Science at Patna. So he'll be taking over from me. He's also an ITOP scholar and is currently pursuing the psychotherapy scholarship. So Dr. Ranjan, we are delighted to have you moderate this session. And I now invite you to take over the proceedings of the evening and formally introduce the chairperson and the speaker. Thank you.
Thank you, Dr. Rachna, for your kind words. I think rightly you have said the psychodynamic approach in child and adolescent has not been discussed in contemporary right now in the most of the forum. So it's very, I hope so it's very meaningful and very useful for the participants who were actively participating in today's session. Also, we all know that child and adolescent, the most of the behavior is in the background of inner emotional world or inner voice through their context and through their experiences. The experiences can be happy, can be traumatic, or it can be difficult. So that makes the child, shapes the child as an individual later on. So I hope that today's session will be very insightful one from our esteemed speaker. Before we'll begin, some key point for the participants also that the participants are requested to post their question in the chat box. Also, we will compile all the question, me and Dr. Rachna, and we will have a fruitful discussion at the end of the session. They should remain muted throughout the session, so that there will be no disturbance throughout the session. And now it's my privilege and honor to introduce our today evening chairperson, Dr. Pratap Saran sir. He is my teacher, he is my guide, he is my mentor throughout my post-graduation day. Right now, he is head and professor and head at All India Institute of Medical Sciences, New Delhi, at the Department of Psychiatry. Sir is also running student affair clinic at AIIMS, New Delhi. Sir has a keen interest in that also. Sir is also, I think, a resource faculty of ICAM Academy. Also, Sir has served as the president of Indian Association of Child and Adolescent Mental Health. So this this shows that sir has a lot of interest in child and adolescent psychiatry. Sir has a keen interest in psychotherapy also. So I think so that will be more useful to the participant, because sir we will look forward to sir, and for formally welcome you sir for this particular session. Now I request Dr. Pratap Saran sir to introduce our speaker, Dr. Varghese P. Punno sir, and also the topic with the brief words. Over to you, sir.
So thank you, Rajiv. And introducing Dr. Punus Varghese is a joy. I've worked closely with him in Indian Association of Social Psychiatry, and he's one of the most cordial people to work with, and very well informed, also very congenial. As we know that he's the dean and he's the principal and professor of psychiatry at Kottayam Medical College, and it would be a pleasure. I missed hearing him in Raipur, so this gives me a chance to have not only the highlights but the entire rewind of the presentation. So I look forward to hearing you, Dr. Punus, and I'm sure that the students are going to, and the listeners are going to gain a lot from your presentation.
Thank you. Good evening, all of you. Especially, I'm very happy that Professor Pratap Saran is chairing this session and Dr. Rajiv is moderating. At the outset, I should express my sincere gratitude to Dr. Kishore, who was there in Raipur when I presented this topic, and he suggested that why not we take it up in the online platform where IPS Faculty Development Subcommittee, IPS Psychotherapy, ITOPS, PG and UG Education, all these fora come together so that there can be a wider discussion. So thank you, Dr. Kishore, for that particular initiative. And I should also thank Dr. Rachna, who has very happily done the coordination work. And I hope she will be sharing the slides also from her end. This is essentially the same, almost the same. I have made some modification to the presentation which I made in Raipur a couple of weeks ago. The title, Understanding the Child's Mind, the Application of Dynamic Psychiatry. In fact, I am not a trained child psychiatrist, but I developed an interest in child psychiatry just out of necessity, because there was a need for someone to take up the child psychiatry when I joined my institution way back in 1997. So during my PG training, I still remember my professor, James T. Anthony. He was a person who always stressed on the psychodynamic approach, whether it is in adult psychiatry or particularly in child psychiatry. But later on, as I got into the further training and experience, the entire focus was on the diagnostic category system, followed both by the ICD and DSM. And in that process, somewhere we lost that particular emphasis on the understanding the child's mind in a deeper way. I was looking for an opportunity, and when it came up in the WDP at Raipur, I suggested this topic, and that was approved for for a lecture. So I should also thank Professor Roy Kallivelil, who was again instrumental in getting this into the main platform. So can we go to the slides? The next slide, Dr. Rachna, please. So it's about how we go about this presentation for the next 35 minutes or so. Can I have the next slide?
So I'm just trying, sir, 1 second. I think there is some mistake.
Don't worry. Childhood and adolescence are the phases of life in which psychodynamics is perhaps most relevant.
Is my screen visible?
Yeah, it's visible. You can go to the slideshow mode.
Yeah.
Okay, fine. Thank you. Childhood and adolescence are the phases of life in which psychodynamics is most relevant. And the entire landscape of the internal world of the child is formed in this very critical period of life, which happens very early. So, apart from the brain development, it's the relationships which the child makes with his parents, siblings, or other people around, the events and the experiences which sculpture the child's mind in a very unique fashion. So, this internal world, the internal representation of the external world and relationships, these are all formed in this crucial period. Next slide. So, that is the reason why there is a particular relevance for dynamic psychiatry when we understand the problems, when we see a child in that particular period of life. Can we move on to the next slide? So the presentation is organized in such a way that we'll have a quick look at the present scenario of psychodynamics in the practice and training of child and adolescent psychiatry. And then we would briefly examine the need for a shift from the present checklist approach, the so-called categorical approach, the approach which is needed to generate a categorical diagnosis as per ICD or DSM. And we'll briefly see how the basics of psychodynamic approach can be employed in the clinical assessment in our day-to-day clinical practice. And then I will try to exemplify with a usual clinical problem. A clinical scenario will be described, and then we'll briefly touch upon what a psychodynamic formulation is and the role of psychodynamic formulation in child psychiatry, and briefly just touch upon the applications in clinical settings, and then a few comments on the considerations of including this approach in the postgraduate training, which is a gap which we feel, and we'll summarize and conclude. So that's how we plan to go. Next slide. So when we look at the scenario of the current training and practice of dynamic psychiatry in child and adolescent specialty, we know that the entire focus is on imparting skills in eliciting symptoms and findings aimed at the so-called checklist completion and the criteria matching. And that generates a diagnosis as per DSM-5 or ICD-11. In fact, I am working in a center where we sit with pediatricians and they're training in the trainee psychiatrists also. Everyone finds this approach very simple, easy, because one need not go into the deep, in-depth interview. We can just listen to the symptoms just like we sit in the pediatrics OPD or maybe in the psychiatric OPD, and that makes it easy. And also the current training focuses on the pharmacotherapy. Maybe I should apologize that mostly limited to pharmacotherapy and sometimes some amount of psychotherapy, which falls mainly in the behavioral domain, and the parent training based on behaviorism and some educational and rehabilitative intervention. So that is the very limited child psychiatry training a DNB trainee or an MD trainee receives in an average center in India. Next slide. So the psychosexual developmental struggles, the object relationships, which are so important in understanding. I think Professor Pradap Sharan made a presentation again in Raipur regarding this particular aspects. The so crucial attachment and bonding which happens or develops in the childhood and adolescence, or maybe even from infancy, and the different phases of cognitive development, personality development, and moral development. So these, unfortunately, these topics or these aspects of understanding are disconnected from the clinical training. The formulations or the diagnosis we make and the interventions, and even for an MD or DNB examination. No. So this for practical clinical situations are disconnected from this kind of theoretical and they are very, very unfortunately relegated to a theory exam, or maybe taken up. Sometimes they might be, if the examiner is interested in child psychiatry, it might be taken up for a part of the viva. So that is the state of affairs now. Next slide. Because I am particularly focusing this because this particular seminar is partially sponsored by, supported by the ITOPS and the IPS PG education group as well. So we need to have a application of mind in this area as well. So with this situation, when we look at whether this particular pattern which we have developed is a service or a disservice, of course there are benefits of our current approach, especially with the competency-based PG medical education suggested by the National Medical Commission. So the ease of teaching and learning, it's actually beneficial. Our present approach is beneficial. And the ease of communicating to medical professionals, especially to pediatricians. And the ease of deciding the pharmacological management and the behavior therapy. And as we have been commenting, the disservice is definitely the fragmented understanding of the child's mind. And we are trying to describe the what and sometimes how, but the answer to the question why doesn't emerge from our current training and clinical practice. So we miss the opportunity to engage in meaningful psychological interventions. As I am happy that this crowd, I find Dr. Sai Kumar and the psychologists also are also there. Even when psychological approach is there, many a time it is limited to the behavioral approach, as I mentioned earlier. So this is just to look at the present state of affairs. Next slide. So we need to understand the child in a better way. It's not just adult psychiatry adapted to the child psychiatry practice. As the saying goes, a lizard is not a small crocodile. It's different. A developing child is different in many ways. Next slide. So we need a shift of focus from just listing the symptoms and eliciting the signs. So the shift is needed from this checklist approach to the understanding of the child's internal world, the child's fantasies, fears, the object relations, the unconscious conflicts, and the developmental processes. And the behavior and the symptoms should be understood as reflective of the inner world or colored by the inner world. So this is what essentially the concept of the psychodynamic approach in childhood. Next slide. So the question, rather than what is the diagnosis of this child, we need to ask ourselves, or we need to teach our trainees, focusing on why this particular child is having this particular problem at this particular time. So unless we answer this question, we cannot claim that we have clearly understood the child's problem in its wholeness. Next slide. So that is the context in which the psychodynamics should come back to the assessment and management in child psychiatry. And before we go to the next session, it is the next part of my presentation. These are the fundamental. I also find that there are many postgraduate residents who have joined this particular topic. So this is the entire psychodynamics we are not going to discuss here. I presume that even the residents who have joined are fairly acquainted with the fundamental assumptions of the psychodynamic approach. The first and foremost is the central importance of the unconscious mental functioning. Second is every behavior can be symbolic. The symbolic meaning of the behaviors which are reported by the parents or observed by the clinician. And the third basic assumption is the existence of an internalized unconscious conflicts. And the fourth one, again, somewhat related to the second concept, the meaning. What does the symptoms tell us? What is the child trying to tell us? What is the meaning of the symptoms? And finally, a usual blind spot is the transferential issues. The transference-based thoughts and behaviors are critical. So these 5 fundamental assumptions are at the core of understanding the child's mind from a psychodynamic perspective. Next slide. So we focus on the unconscious mental process which are outside our conscious awareness. So that is acknowledged. The innate forces for the impulses and behaviors, the drives, are acknowledged. And the possible defense mechanisms, which are the unconscious strategies which protect the ego from experiencing the distress. So this psychodynamic framework, so that kind of a framework we need to assume when we try to understand a child's problem. Next slide. So again, a basic concept to put it in a simple form. The ego functions when it's a common usage in psychodynamics about the ego functions. I tried to put it in simple terms, especially for the trainees who are attending this session. What does this really mean? So there are at least 7 aspects in the appraisal of ego functions. The ego function, essentially the concept of the ego is it is a function which moderates between the drives of the id and the reprimands of the superego, the basic psychoanalytic concept. And second is the child's ability for reality testing. Again, depends upon the developmental stage. And the third important aspect is the impulse control, the ability for managing impulsive responses. And the fourth is the affect regulation and defense mechanisms, object relationships, and self-esteem. So probably these are the areas which is generally referred to as the when we talk about the appraisal of ego functions. So the impulse control, affect regulation, possible object relationships the child has made, sorry, the possible defense mechanisms which are employed by the child in an unconscious fashion, which can result in the symptom manifestation. Next slide. And the usual defense mechanism. So most of us who are working in child psychiatry, we know that the several defense mechanisms. Out of the several defense mechanisms, I have just tried to shortlist these 9 usual defense mechanisms which are encountered in the practice of child psychiatry. Of course, the repression, the undoing, projection, isolation, somatization, regression. Perhaps regression is very, very commonly encountered in child psychiatric practice. Introjection, intellectualization, and rationalization. So rather than having a just theoretical knowledge about these defense mechanisms, if you closely look at the symptoms exhibited by the child, it is many a time enlightening to understand that how these defense mechanisms are coming into play in the generation of symptoms. Next slide. And when we take in the assessment per se, in the psychodynamic history in child assessment, it's important to develop a habit of developing a narrative description of the symptoms by collating information from different sources. A narrative description from the point of view of the child or the parents who are reporting, that is important, and it should be placed in context as perceived by the child, parents, and the culture. So this is important rather than listing out the symptoms. A narrative description in the context as perceived by the child, parent, or the culture. And the developmental history, we always focus on the developmental history, but again, unfortunately, developmental history has become narrowed down to the neurodevelopmental milestones. But the developmental history should be dilated a little bit more, which includes attachment and bonding, the child's interaction with the caregivers, parents, and maybe in Indian context, there could be other caregivers as well, the siblings, even the animals, the domestic animals or the pet animals around, the toys, the solitary and joint place in which the child is, the cartoon characters which could be a part of the child's fantasy life, and even inanimate objects. So this developmental history is very, very important in understanding the psychodynamics. And again, the family history should not be narrowed down to understanding the genetics or the possible, it is beyond the actual nature of the family interactions going on. How the child is valued in the family, whether the child is favored or discriminated, the family beliefs about the reason for the symptoms, and the faith-based actions as treatments. So this can be a little sensitive in our culture, because many a time the parents do not choose to disclose all these things, especially when they come to the setting of a modern medical facilities, like in most of the hospitals where we work. So unless we go in a non-judgmental manner, their family believes about the reason of the symptoms and the kind of treatments they are taking in addition to what treatment, or sometimes these treatments can be complementary, sometimes they may be, there could be treatment subversions because of this problem. So all this, an effort should be made to understand when we take the history, especially when we keep psychodynamics in the background. Next slide. So here I'm trying to give a very simple example, a very common scenario in our clinical setting, that a child, a school-going child with medically unexplained abdominal pain. This case was referred by the pediatrician or a pediatric surgeon. And the initial evaluation, our routine evaluation, the diagnosis of somatization, separation anxiety disorder was made by the resident. And then when the consultant sees additional diagnosis like a suspected learning disorder or maybe a inattentive type of attention deficit disorder. So that is a kind of diagnosis which was generated. And the behavioral interventions, educational interventions, with of course some pharmacological interventions for the anxiety component was introduced, but with very limited success. So when this particular child is not getting improved, it's being taken up for a case conference, and the pediatricians feels that something is missing. The psychiatrist is not happy with the progress. So it was decided to proceed with a change in approach. Next slide. So further exploration with which incorporating the psychodynamic approach, the child had an opportunity to give a more narrative description of what her inner state is. The child disclosing her disappointments. My birth disappointed them. They all wanted a boy. The child, she was the third among the last, the last of the three siblings. And there was a belief in the family that due to her unlucky birth star, all these things happened, and father had an accident shortly after her birth. The entire family stories implicating this particular inauspicious time of birth as a cause for all several misfortunes in the family. So discriminations within the family, where the child is kept out of many family functions, the arguments between parents of having another baby, they wanted a male child, that she is having certain nicknames, like she was very thin, lean, nicknamed as Drumstick by the family circles. And she was harboring hatred for her father. At the same time, she was feeling guilty about her wish that let the father die. And she had apprehensions when the mother, there were the family talks. The mother is nearing the age of 40, and if she gets pregnant again, there can be complications. All these anxieties were haunting her. So this kind of getting connected to the child's fears, the child's guilt, the child's subjective experiences of discriminations in the family opened up a different kind of understanding to the entire problem, rather than the DSM diagnosis of a somatization disorder or a separation anxiety disorder or a specific learning disorder. Next slide. So with this additional information, can we go to the next slide? So you can see the DSM-ICD code, our categorical diagnosis on the left side, and the psychodynamic formulation, which is more of a narrative fashion, which reflects in a more understandable way about what is going on. So the medically unexplained pain, understood as an internalizing disorder, the background of a family environment which is not very conducive to the healthy ego development, and continued exposure to emotional trauma and conflict. So the defense mechanisms like regression and somatization is evident, and the kind of transferential and the counter-transferential issues, the child was running from different hospitals, different doctors, the kind of counter-transferential issues, and of course the transferential issues are also focused in the psychodynamic formulation. So this brings out, it's a very simple example where the psychodynamic approach, how this can make us better understand the child's problem. Next slide. So the linking the child's symptoms to the unconscious conflicts, defense mechanisms, and developmental stages, that is essentially the limited psychodynamic. I'm not talking about the classical way in which psychodynamics or psychoanalysis is done, but a simplified, or maybe we can even call it a diluted form of the psychodynamic understanding in our day-to-day practice. So there is an effort to link the child's symptom to unconscious conflicts, defense mechanisms, and developmental stages. Next slide. So having said the advantages of this psychodynamic approach, I am not suggesting that we should replace the DSM-ICD category approach with the psychodynamic formulation. What I am suggesting is that psychodynamic formulation should be in addition to the categorical diagnosis. So it supplements or complements the diagnosis which we are making. So the psychodynamic formulation compels the clinician and the trainee to explore the inner mental world of the child, and it attempts to offer psychologically meaningful explanation. So this meaningful explanation can lead to the approaches in psychotherapy, psychodynamic psychotherapy, which can be expected to have a positive effects which can go beyond symptom remission. So that could be one of the advantages when we resort to a PDF. Next slide. So the psychodynamic formulation should have a narrative description summarizing the symptoms and the current state of mind. As we have already seen, the context and the history, which links the current problem to the early childhood experience and trauma, and the dynamics which tries to identify the core conflicts and defenses, and of course the usual blind spots, the transference and counter-transference should be explored deliberately, and that may serve as a magnifying glass to understand these issues, and of course the prediction of how the child will react to therapy. So these are the essential components of the PDF. Next slide. And I deliberately I haven't included the detailed aspects of this applications treatment. My main intention is to focus on the need to have a psychodynamic approach, but for completion's sake, just to make a mention about the applications in the treatment, the psychodynamic play therapy, the child's limitations in the expression of complex emotions verbally. So the play will be a substitute for the verbal free association if you want to make a comparison with the adult psychiatry. So the child's play can be understood as an effort to play out their express their inner struggles symbolically. So a holding ground or a holding environment can be created for the safe psychological observations of patterns which can identify the defenses and conflicts. And this can also serve as a method for collaborative alliance with therapists. Next slide. And there are several indications for psychodynamics, possible indications for psychotherapy, psychodynamic psychotherapy in children. As we all know, the anxieties and phobia, which often uncovers the hidden fears driving avoidance. When in the categorical approach, we never go, we just name it, what kind of phobia, or whether it is a panic anxiety, whether it is a social anxiety, or whether it's a specific phobia, etc. So we should go beyond, and the hidden fears which are underlying the avoidance may be helpful. So that could be one aspect which can indicate that it could be effective. And of course, depression, exploring the loss, self-esteem, and the hidden anger which might be there in when a child is going through a depressive phase. And of course, the trauma and loss, the processing and integration of traumatic memories through the safe play. And the well-known psychosomatic disorders, like, say, for example, a child with bronchial asthma, a child with migraine, eating disorders, etc. And chronic medical, when children are treated for chronic medical conditions, like, for example, we have a lot of children attending the type 1 diabetes, or the type 1 diabetes clinic. They call it a Mittai clinic in they do it in the Institute of Child Health, leukemias, nephrotic syndrome, etc. And on the positive side, apart from treating this disorders, a psychodynamic approach can be useful in tracking and facilitating the healthy personality development. Next slide. So before we conclude, just one or two slides about the characteristics of children who would benefit from psychodynamic psychotherapy. Not every child is suitable for to be taken up for the psychodynamic approach. Of course, they should have a some conflict-free areas of functioning, and children who are able to relate and communicate well at the age-appropriate levels. Children who demonstrate interest in some areas like school, hobbies, etc. Children who are aware of symptoms and when there is a wish for change. Children who can understand metaphors, and children who have a somewhat stable affect. So probably these are some of the characters. Just like we select adult clients, also here also some of these characteristics are important. Next slide. So, of course, not only the children, we know that parents are also involved in when there is a psychodynamic approach, the parents should have a supportive approach, maintaining scheduled approachments, ability to form alliance with the psychiatrist, communicate about the child's outside, about the child outside the child's hour, participates in monthly meetings. They should limit their inquiries to the child about the therapeutic process, and there should be a willingness to keep the psychiatrist or the psychotherapist informed about significant development. So we should be aware of some kind of a what is referred to as a homeostatic resistance from parents. So the parental factors are also important. Next slide. So do we have evidence for effectiveness? Evidence for psychodynamic psychotherapy with children and adolescents There is not limited literature, but this is something which I have found, a systematic review of nearly 120 papers. This finds evidence of effectiveness in internalizing disorders like anxiety, depression, children experiencing adversities, etc. For these conditions, there is some evidence is emerging. And also, there is some evidence for the sleeper effect. That means the benefits of psychodynamic psychotherapy going beyond symptom remission, and they continue to grow and consolidate even after the formal sessions have been concluded. So it is possible that the child may internalize the new way of processing emotions. Next slide. So we should have a firm footing in theory, which is essential in training. So I'm just mentioning it. Next slide. The research also, there are some promising researches coming up, like there are certain, the operationalized psychodynamic diagnosis, psychodynamic intervention rating scales, psychodynamic functioning scales. So these are some of the scales researchers have used when the psychodynamic approach, even though it's we may think that it is a qualitative thing which is difficult to study, but reasonable good research using these scales can be encountered. Next slide. So finally, this is my last slide. So what I wanted to emphasize is a psychodynamic approach in children helps to develop a narrative experiential picture. The identification of internal conflicts like the aggression, the guilt, the abandonment, etc. The ego functions, the ability to, so training the ourselves to assess the ego functions, the defenses employed, and the object relationships, the internalized pattern of relationship with parents and significant others. So these are the essential components which we need to train ourselves and train our future trainees. The psychodynamic approach, which explains the why of the symptoms which are presenting now, so that leads to a meaningful psychological interventions beyond symptom remission, and which help us hopefully evolving a clinician therapist who has a deeper understanding of the child. So thank you very much for your listening. Thank you very much.
So, thank you, Dr. Punus. All of you will agree that it was a very comprehensive look at how psychodynamics works in child's psychiatry, starting from what kind of training is available right now to clinical presentation of a case, which helps us to understand how it actually works in practice, to how it should be introduced in training going forwards. And there were lots of technical nuances that were covered in a very simple, it seemed to be simple, but I think the coverage was quite comprehensive. I will now hand it over to Rajiv and Rachna to carry on with the discussion and maybe speak a couple of words towards the end.
Thank you, sir. I think there is no question in the chat box right now. I think so. As anyone want to ask directly, they are welcome now if they want to ask. Okay, but we have one question from Dr. Rajamani. Sir, to Dr. Punus, how do we catch ourselves wanting to be the ideal parent, and how do we manage the child intense idealization of us without turning the actual parent into a villain? Very, I think, a pertinent question, sir, regarding the parent-child relationship.
See, a psychodynamic approach is, we should confess that it's a very tricky situation where parents can feel guilty about the kind of upbringing they had given to the child, especially when childhood trauma, the early relationship, the problems in the early relationships, and the ego development. Most of the time, children are brought to us relatively later in their life with certain symptoms. The moment we start going to the early childhood, speaking about their origins rooted in the early childhood trauma, or maybe because of the unhealthy object relations which emerge, it can sometimes make the parents guilty. And again, the therapist countertransference also can come into action. We ourselves begin to reflect how, as parents, we have managed, or were we aware of these kind of things, or how far a person should be deliberately looking into these things. So that is the reason why as I confessed at the initial part of my presentation, I am not the best expert to provide solutions to this kind of very pertinent question. But this is a different way, or maybe the method in which we should train ourselves, and we should be more self-reflective about the way in which we approach child psychiatric problems. We all should. It's not that easy. It's not the easy path to go when we venture to take up the child psychiatric, the psychodynamic approach. And I find that several questions are coming up in the chat box and the chat box. Let me see.
The next question from Dr. Krishna George. What are the experiences of using the concept of transfer and counter-transfer in the therapy with children? Yeah. Especially in children, not adolescents.
So that's from Dr. Christina. Christina has raised the question of transference and counter-transference. As I mentioned that the transferential issues and counter-transferential issues are perhaps the biggest blind spots in which are encountered when we take up the when we approach in a psychodynamic way. So the only way is to look at, to reflect ourselves, to look at the transferences which are developing between the child and the therapist, and try to understand the symptoms, understand the child's development in that terms, and also one need to reflect very honestly about the counter-transferential issues. Especially when training our postgraduate residents, it is very, very important to make them aware that these are definitely the factors which work out in the assessment as well as in the therapeutic. It's a kind of magnifying glass effect. The actual problems, the relationship with the child and the parents, we are blind to those kind of things. So those issues may be reenacted in the clinical scenario. And when we are deliberately making an effort to look into it, it becomes very evident. So what happens in the family, what happens in the real life scenarios, so that is reenacted in the family. So the thing is that the transferential and counter-transferential issues become evident, and it becomes visible once we begins to look at it. So that sometimes can, I'm not suggesting that it should be applicable in every case, but in many situations, especially the generalizing kind of symptoms, the externalizing symptoms, these issues can be very important in understanding and management. I'm not sure whether I am satisfying the people who have raised these questions, but we'll go through the chat box and maybe we can come back for a discussion if the time permits. Dr. Bhargav makes a comment that in some scenarios, the parent and child are pitted against each other with respect to what their main complaints are. So how do we bring them together in treating these issues and ensure that one party doesn't feel we are talking side? Very, very important. In one of my slides, I have highlighted this aspect. So the narrative, the experiential narrative from the child can be different from the concern of the parent. And of course, what the culture says. So whenever a narrative is formed, it should not be just the complaint made by the parent alone. A child, even if the child is very young. So we may tend to think that this is applicable only when the child is maybe in the Piaget's stage of cognitive development beyond that age of 12 years or no. No, I think that even young children, their perspective of what brings them to the doctor, or what is their suffering, or what is their distress, has to be obtained in a, of course, in their experiential narrative manner. A child's perspective, a parental view about it, they should be separately addressed and try to connect them rather than as Dr. Bhargav put it, which usually it can happen that it can be a matter of dispute in the clinical setting. Role in adolescent suffering from Dr. Megal asks about your views on role in adolescent suffering from addiction and how to approach. Yes, in child and adolescent psychiatry, the application of a dynamic approach is not limited to the early years where all this object relationship or early psychosexual development happens. The developmental stage. Addiction is a very good example where psychodynamics has its application. From the good old description that any addictions are oral tendencies, etc. But beyond that, what actually happens, the real reason for, apart from the neurobiological explanation, sometimes an addiction or the use of substances can be a protest or a rebellion against the stifling attitude in their school, or so this kind of meanings, this kind of symbolic reasons why a child or an adolescent chooses to use substances. Unless we explore it rather than just looking at what happens at dopamine or what happens at the serotonin or opiate, that doesn't make a complete picture. So it's a very good example where a childhood adolescent substance use is a situation where the psychodynamic aspect should also be looked into, so that the parental involvement rather than just a behavioral intervention from the part of the parents doesn't work. So unless we incorporate the psychodynamics, then it becomes the simple behavioral approach may not yield the best results. Dr. Rajamani asks, a child begins to improve and express autonomy. The parents sometimes abruptly pull them out of therapy or miss appointments. How do we proactively address a parent's conscious resistance for their child? So, Dr. Rajamani, I bring your attention to a concept which I mentioned in the homeostatic resistance. So this is something which we come across very often when we go for a psychodynamic approach. There is even though the parents want a symptom remission, and the child, when is brought into the therapeutic process, at some stage, the parental resistance can be manifested as missing appointments or deliberately. It may not be deliberately, but the parental behaviors can sabotage the therapeutic progress. So we should anticipate this kind of issue. So the parental resistance, their unconscious efforts to maintain the homeostasis, which should be brought out, and they should be given insight to the kind of the subverting or maybe sabotaging effect these attitudes can have. So the educating them is very important. Parenting and Dr. Ipsa Basu asks, many a time parenting and home environment is not optimal and might contribute to the maladaptive process in the child, leading the development of psychopathology. And often the parents are not willing to come for sessions saying that the child has got a problem, not them. So how to approach this situation? So this essentially the response to Dr. Ipsida Basu's query is in continuation of Dr. Rajamani. I said in one of the slides, I mentioned some of the parental qualities which are good criteria, which are better criteria which for children to be selected for psychodynamic approach. Whether we take them up for psychodynamic approach or not, having a separate session with parents is important, irrespective of which approach you take in child psychiatry. And I think that is a very challenging area, understanding the parental dynamics, the parental resistance to change, the parental projections of their the parental blindness and denial of problem in the family dynamics. All these are challenging issues in child psychiatry. And I should again emphasize that this is not confined to the psychodynamic approach alone. Dr. Rajamani again has a final question. How do we manage the overly compliant, perfect pleaser child who gives us exactly what we want? How do we gently disrupt this over compliance to actually reach the angry split of messy parts of the internal world? Thank you. Okay. I think that it is a suggestion rather than a question. About, see, the next question by Sanjeev, also standard parenting guidelines. So combining these two queries, my comment is that our routine parent education strategies are usually focused on the behavioral approach and learning approach. And recently we have added, spiced it up with neurobiology also. But essentially what is missing in parental teaching and parental education is the psychodynamic component, which is so important. So I think there should be an effort to complete or maybe to make the parent educational material, the parent training schemes by adding this psychodynamic components in of addition to the behavioral approach and the neurodevelopmental approach, neurobiological approach. I think I have quickly covered these questions. I may not be in the perfect way the people have expected. Anyway, the time permits only a limited kind of interactions, and of course my limitations of training in psychodynamics also.
Hello, one last query from my side, that in your experience, what about the transference and counter transference? Is it always detrimental or it is beneficial also in child and adolescent?
Yeah, it is there in every situation. But in practical situation, this cannot be, for practical reasons, this cannot be taken up in every session. But maybe in a situation where in some of the questions raised here, when there is actual parental resistance or the child's failure to improve from more conventional approach. So that is where we go for this, as exemplified in the case scenario which I described. So in our routine child psychiatric practice, it is not practical, or it is not feasible to go in for a psychodynamic approach in every case. Maybe in situations where it seems important, or when we are stuck with our conventional kind of behavioral approaches, there is a scope for looking at psychodynamics, and that can offer a better solution for the problem.
Thank you, sir. Dr. Ansur, you want to ask? You are mute. Please unmute yourself. Yeah.
So I wanted to ask, sir, how do we assess for suitability of psychodynamic psychotherapy in the adolescent population? The specific question is being that how do we assess for the reflective capacity of the child to be engaged in psychodynamic work, and also what frame should be approached as? So this was what I was.
Dr. Anshul, I'm afraid I didn't get you because can you
sir,
louder?
Yes, sir. I will repeat the question. Sir, I just wanted to ask as to how to assess for suitability of a child for psychodynamic work. That is, how to check for reflective capacity and the ability to mentalize, which is required for psychodynamic work in somebody.
Thank you.
Yes,
That's a very important question, practically very relevant question Dr. Anshul has raised. In one of my slides, I have listed out some 7 criteria. It's not actually criteria, certain abilities for a child to be taken up for psychotherapy and certain parental qualities. So because of lack of time, we did not go for that. You specifically asked about the abilities for mentalizing, the abilities for understanding, the abstraction, etc. Of course, that depends upon the child's level of cognitive development. It's child's verbal ability, the child's ability to, I mentioned in one of my slides about the ego strengths. So a child can be suitable only if the child has got a affective stability, the child has got at least some ability for reflections and mentalization. Of course, that is mostly a subjective assessment rather than going for any definitive assessment. And as I mentioned towards the last part of my presentation, there are some scales. There are some scales which have been used by researchers. I haven't personally used any particular scales to assess the suitability of the child, but somebody, if they want to go into the research, of course, there are certain tools which help us to identify the suitability of a child or the suitability of parents who should be taken up into the psychodynamic approach. I think my slides, if Dr. Rachna can share it to the people who are interested in. There is one particular study which I mentioned, a review. The relatively there is a scarcity of very well conducted studies with regard to the effectiveness of psychotherapy. The one particular study which reviewed more than 120 studies may detailed description. Some of your questions get answered in the methodology of some of the studies reviewed in that particular cited study. Rajana can share to the slides to the people who are interested.
Thank you, sir. Dr. Shai wants to ask one question. Dr. Shai, please.
Yeah, thank you. Thank you very much. I really enjoyed Dr. Verghese' presentation. He proved himself that he's a great teacher to teach some of the very complex ideas. I just wanted to share a case. Right now I'm dealing. Just about a minute or two I will just take. A 14-year-old girl was treated for, has been treated for severe depression. And she has been having symptoms for the last 1.5 years of time. Now she is recovering. But the recovering path is very tough because the symptoms are so severe. She had suicidal wishes and things like that. So the family was really going through a very tough time. The father also was treated for anxiety attacks and symptoms. So during the stressful period in the family, the father told the child that because in the fear that he is going to die, so he told the child who was already vulnerable and having through these problems that Nida Pathukano, that is, you only have to look after hereafter. The child took it so intensively, this particular point, and then she kept it. That point did not come out later for some time. But when she was recovering from the depression, she developed affection with her maternal cousin, cousin brother. Otherwise, he's a Muramapalli. This child, the person whom she can marry later if there's an approval. So she developed affection to an extent of embarrassment and resistance from both the families. Now they are not able to, separate them too. The idea is that what she developed was that the father told that you have to look after hereafter the family, but she took it that how will I be able to look after unless otherwise I am looked after well. So I need to be looked after well. For that, the mother was quite, harsh on her on many times. So she couldn't get affection from the mother. The father is affectionate, but his affection is resisted by the mother that you are pampering her. So she got related to the boy. Now they find it very difficult to separate them two and then manage it. Then she's threatening now with suicidal threats and deliberate self-harm and doesn't want to get into the house and all that. Now the symptoms are becoming more hysterical and behavioral than otherwise she was struggling with psychosis. The point I'm trying to tell you is that the dynamic approach can be applied not necessarily in the mild mental disorders, but also in the severe mental disorder when sometimes people are recovering, and it can also play up and complicate the management and recovery process. Thank you very much. Very nice presentation.
Thank you, Dr. Sai, for that reflection from your side.
Thank you, sir. One last question in the chat box, sir. How are the sessions scheduled? Is a longer period between the session okay, or which is preferred? Probably it's related to in adult psychiatry also and in child and adolescent psychiatry regarding the psychodynamic sessions.
Yeah, see, as I said, in our setting, I work in a consultation license setting. We usually have a very close license with the pediatricians as well. So when we think that a psychodynamic approach is needed, it is not usually taken up in the first session. Of course, after having, because that can be, as I said, it can be, the parents may feel a little threatened. The parents may feel guilty and anxious when all these things are being to be explored. So when the child is usually, the usual scenario in my experience and in our practice is that when the child is not experiencing the improvements, we take a decision to look at the psychodynamic aspect also. So then we give separate sessions, of course, not in the regular child OPD. Our child OPD is usually on Saturdays, and we give it on other separate time, separate sessions are being planned. So I think it depends upon the individual center and the logistics and the time availability, the resources availability, and even the expertise availability also. So it's flexible.
Thank you, sir. I think now questions are now completed. So now I request Pratap Saran sir to his own thought about today's presentation also, and also regarding if he wants to comment something regarding the psychodynamic approach in child and adolescent, his experience also.
Thank you, Rajiv. I think, as I mentioned at the beginning, it was a tour de force. It was a very comprehensive presentation, and even in the question answers, Dr. Varghese showed that he has a multifaceted approach to dealing with children. Psychodynamics, one of the interesting things is that every psychodynamics practitioner will have a different approach. So in that sense, some of the answers that I would probably give slightly different answers to some of the questions, and that is not taking away the veracity of what Dr. Varghese has presented. I agree with that, and still I have slightly different things to say about some of the points. One of the points that was about whether there can be a standard practice guidelines, parenting guidelines. So this question was asked of Winnicott, who's supposed to be the
Pratap
best.
sir, you are not audible.
Rajiv, can you hear me?
Yeah, I can hear you, sir. I can hear you.
Right.
Yeah, now you are audible.
Right. I'm sorry. So one of the questions about standard parenting guidelines, Winnicott, who's considered the greatest child psychoanalyst of all times, was asked the question about what he could, whether they could be a guideline of that kind, or whether he would like to put up a guideline. He said that every child and every parent is different, and every child-parent relationship is different. So there cannot be a standard parenting guideline from a dynamic perspective. There can be parenting guidelines from behavioral and other perspective, but from a dynamic perspective, they cannot be, because each relationship is different. The second point that I would want to make, which is not actually different from what Dr. Varghese talked about, and is the question about what is an appropriate kind of client for psychodynamic psychiatry. There is nothing like an appropriate client. Every client can be appropriate. The way you approach a client can differ. Like, for example, if a person does not have much reflective capacities, you might go for supportive kind of dynamic work. If a person has reflective capacities, you may go more for exploratory kind of dynamic work. And that is something which Dr. Sai Kumar actually brought out very beautifully, that even with a person who may have psychotic depression, there will be a point at which you might be able to intervene effectively. Another point was about if a person is a pleaser, what do you do? No pleaser stays a pleaser for a very long time. As from a natural kind of approach, every parent, every therapist will sometime or the other disappoint a client, because you cannot be a perfect kind of empathizer. You will have empathic failures somewhere or the other, and all very idealized relationships will have disappointment. So one has to worry more about when you are very disappointing to clients rather than when you are when they're idealizing you. After some time, at some point or the other, the idealization has to kind of hit a wall. These are some of the points that I thought I would want to emphasize, and maybe Dr. Punuz might want to respond to some of these things. Other than that, I think it was very informative session. It was a very reflective session. And I would like to thank Dr. Kishore, Rajiv, and Rachna for making it such a. This hour was worth it. Thanks a lot.
Thank you, sir. Thanks a lot, sir. Dr. Burgess, sir, want to say something, or should I wind up the session right now?
Thank you, Dr. Pratap Sharan, for those words where we need to. So all this indicates that we need to have a deeper look into this particular aspect. And my intention for making this presentation is also to highlight that in our training, in our practice and training of child psychiatry, we should have a more emphasis on the dynamic psychiatry in childhood and adolescence. In our training, or maybe in our examining the candidates, everything where psychodynamics should have its due share. So that was the main intention of this presentation, and more scope for this training should be there. And Dr. Kishore is in this group. The ITOPS is there. We can have some deliberations further how this psychodynamic approach can be incorporated into our training in child psychiatry and the postgraduate level. Thank you.
Thank you, sir. Very beautifully winded up. So what I have understood throughout the session that even for psychodynamic formulation, that is add-on for what categorical classification we have, that what you have said, sir, and also what we are practicing right now, psychodynamic psychotherapy in child and adolescent, that is always add-on what we have evidence with biological treatment and behavioral treatment. With this word, I think now I hand over to Dr. Rachna to conclude the session.
One thing which I would want to say,
yes,
Dr.
Please,
Verghese, was that Dr. Rachna was beaming throughout the presentation. I've seen the few hosts so happy with the presentation. Thank you.
So because I predominantly practice in a CAP setting, it was certainly a joy to watch this, and it was a very fresh perspective because we are so used to, even our formulations, even our assessment becoming so categorical. So this added certainly a very fresh flavor to the whole thing. And I was also learning, I was also curious to know. So I'm really happy that it turned out really well. And it was really nice to see those intelligent exchanges between yourself, Sir Pratap sir, and Verghese Punno sir in this. I think we're coming to a close of this session. It was a very enriching academic session. I would like to thank Verghese Punno sir. I would like to thank Pratap sir, as well as Rajiv, Dr. Rajiv, and Kishore sir for giving us this opportunity. I think this is a very relevant topic, and like rightly pointed out, I think it should be brought into our training curriculum. The upcoming postgraduates, as well as the postdoctoral fellows, as well as the DM residents, should be given this angle of training as well. And I would like to extend my sincere gratitude to IPS as well as the ITOPS platform, and thank all the participants, who participated with great enthusiasm this evening. Kishore sir, are you around? I don't know whether sir dropped out. Okay. I think sir is not there. All right. I would also like to use this opportunity to invite each one of you to our upcoming CME. So we are holding a CME Autism 360 at the Christian Medical College, Vellore, on the 5th of June. In the chat box, maybe I will share the website link so that everyone can join in. We are exploring a lifespan approach, right from neurodevelopment to a lifespan, because transition care, what happens beyond 18 is not very much discussed. So we are also addressing this challenge, and I'm happy to say that Verghese Punno sir, who's here, is one of the speakers. Kishore sir is also doing a pre-CME workshop. So I would like to warmly welcome you to the Christian Medical College, Vellore, on the 5th of June. So thank you. And if there is nothing, I think...
Is it online, Dr. Rachna, or it's only offline? Is it online?
It's only offline.
Okay.
We will have a recording which is made, which we'll upload after 3 weeks. That is through the CMC Connect. That's mainly for our mission hospitals. So CMC has a network of mission hospitals across India, and not every one of those doctors who are in those outposts can actually come here for a one-day CME. So we will have that then in our educational repository. Okay.
Okay.
All right. So yeah. So thank you everyone, and have a good rest of the evening. Thank you.
Thank you. Thank you, Sir Pratap sir. Thank you, Varghese sir. Thank you to everyone and all the participants. Thanks a lot. Good night.
Good night.
Good.